What would you say are the biggest challenges when it comes to working with patients to kind of navigate these potentially negative outcomes
I
elsewhere?
don't think there are challenges for working with the patients
Mm-hmm.
per se. I think the challenge is many patients aren't aware of the issues that could be there in the background, and some of their clinicians may not be either. Also, from a bariatric perspective, they may not be seeing a patient, they may not be seeing their bariatric clinician, and so they may be in an office where sometimes the doctors aren't even aware that they've had a history of bariatric surgery. Many people are prescribing obesity medications because they're so effective for weight reduction, have additional cardiometabolic benefits. Um, with the changes that people experience in nutrient intake with that, if they're not consuming adequate quality diet, they can be at risk for malnutrition. We don't have the same guidelines for nutrition and screening and supplementation for using anti-obesity medications as we do with bariatric surgery, for example. There's much less of the data there than we have with surgery. And so what we need to do is make sure that we're identifying at-risk individuals for malnutrition who could be receiving medications that could cause that. So, for example, if we have older adults who are receiving incretin-based therapies for cardiovascular risk reduction, for example, we need to make sure that we assess them for potential nutrient deficiencies, make sure we assess their physical function to make sure things are improving and not declining with treatment, and make sure that at-risk individuals are seen by a registered dietitian and see people regularly for follow-up. These are highly effective agents, and on average, the results are great for people. But what we want to do is make sure that we identify people who could be at risk for misadventure.
Mm-hmm.
Dietary interventions for people taking these medications can really help to mitigate or offset some of the more common side effects like nausea, potentially abdominal discomfort, in more severe cases, vomiting or constipation, and other issues like that. So I think it's important for us to talk with our patients every time we see them back, to see them back regularly, and to do some troubleshooting if they're experiencing more than would be anticipated symptoms from a GI perspective. I think it's also important to acknowledge that a lot of these are dose dependent as well. And for many clinicians, sometimes the emphasis is more on getting patients to the higher dose to either control their blood sugars or to help the weight come down quickly. Whereas what we need to do is find the right dose for the patient so that they can continue on evidence based therapies that has benefits beyond weight reduction.
What do you normally see that impacts the dosage needed? Are there any kind of other life factors? I mean, we talked a little about women who are in menopause or perimenopause and things like that. And what about with, for instance, like male populations? Or is there kind of like a typical age at which you kind of expect a dosage to be a little different?
Yeah. We don't have really good data with regards to are there special populations in whom
Mm-hmm.
doses or who will be more sensitive to the medication. Intuitively, what we will do is go slower with the dose titration or dose increase titration for people who may be at risk for dehydration or malnutrition. So, for example, if somebody has advanced chronic kidney disease or in older populations, we may start the medication and advance more slowly. I think the important thing to understand is that there's a lot of heterogeneity with regards to what side effects people may experience, which is why it's important to start at the lowest available dose, titrate slowly, see the patient back regularly to work out which dose is right for them.